Good afternoon, everybody. Thank you all for being here today. It was my pleasure to welcome you to our first lecture session, where we have the honor of hearing a truly innovative orthopedic physician in healthcare. That's Dr. Gruner. You can see him right there. Dr. Gruner is a respected physician with a strong record of innovation, patient-centered care, and a strategic leadership. Today, we will be sharing his insights about both timely and impactful. Whether you're a clinician, administrator, student, or healthcare enthusiast, I know you'll walk away with the valuable takeaways and renewed inspiration. A few housekeeping items. We will be recording today's session for those who can't join us live. There will be a time for Q&A at the end, so please hold your questions until then or send them to the chat that's online that will be directly going to me and I will keep track. So without further ado, please join me in welcoming Dr. Gruner.
There's a nice to meet you, everyone. Myrna, there's one person in the chat that said they can't hear. I want to make sure, can someone else just respond if they can hear me? They can hear. Okay, perfect. Might just be that one person. Yes, great. Awesome. Thank you so much, guys. Well, I am very excited to talk with you guys today. I'm a sports medicine physician at Ortho Bethesda and Aligned Orthopedic Partners. And I grew up here locally and look forward to talk to you guys about non-surgical treatments. And I'll take you to the slides. Myrna, if you could let me share my slides, please. Myrna, can you see my screen? Perfect. Thank you. Well, this will be one of many lectures that we have to give to the Bethesda community, and I'm excited to start off. The goal of today's conversation will be to talk about non-surgical diagnostic and treatment options for orthopedic conditions. I do have a couple disclosures. I have a remote monitoring company, and I also an advisor for Accorded. So just a brief background on myself. So I was born and raised in Bethesda, went to Walt Whitman High School, previously a basketball player, did my exercise physiology and biomechanics, medical school and MBA down at Virginia Tech, residency locally here in Georgetown. And then I did my fellowship in sports medicine at Mayo Clinic, which is the #1 hospital in the country. And when I had the opportunity to learn a lot of innovative non-surgical treatment options, I wanted to make sure I brought evidence-based treatments back home to my hometown, and look forward to sharing some of the information today with you guys. I also am board certified in RMSK, which people should know about. So in it, one of the modalities I use frequently in my clinic is ultrasound, which can be used to diagnose and treat many conditions. It helps to look at a lot of soft tissue injuries, which is equal to an MRI, and also helps for accurate, precise injections. And only a few people in the country have the RMSK certification, which allows you to do the diagnosis portion of it. So this is where I trained at Mayo Clinic. It was an amazing center, which was focused on really taking a holistic approach to health for orthopedic conditions. And so we had everything from the fitness gym to the sports medicine performance center to all the different different providers for orthopedics, including physical therapy. And we all came together under one roof to try to come up with a holistic approach when we took care of the patient. And I think that's been our approach at Ortho Bethesda, is how can we bridge a holistic approach. So we have physical therapy in-house. We also have a breadth of orthopedic doctors covering every condition. And I think what's unique about us is we have a new Kensington Sports Performance PT Center. And then we also have a place in Bethesda and a place in Tysons where I practice, trying to provide quick, easy access to care, similar to how it was when I was at Mayo Clinic. So we're going to review the topics for the talk today. We're going to review some sports medicine and non-surgical services, review evidence-based practices for exercise and bone health. And then we're going to talk about some non-surgical treatments. We'll also talk about the evidence behind regenerative medicine and finish up with evidence about some ultrasound guided injections. So before getting into non-surgical treatments, I think it's important for everyone in the community to know what is the top level evidence for what I recommend to a lot of my patients about exercise and fitness. And there's a body called the American College of Sports Medicine, and we came out with a list of guidelines that are supported by the CDC. And these guidelines have focused on several different um, uh, uh, recommendations that every doctor and every patient should know about when it comes to exercise. First, if you're an adult 18 to 65, moderate intensity for a minimum of 30 minutes on 5 days a week, or vigorous intensity. So moderate intensity is like walking briskly, or vigorous intensity is exercising to the point where you're out of breath for a minimum of 20 minutes a day, at least 3 days a week, is really important for your cardiorespiratory health. Secondly, every adult should also perform strength training. And this has been updated over the past years, but at least 2 days of strength training is recommended now. It's important for bone health, as your muscles are one of the most important predictors of having healthy and strong bones. The last piece, the number one reason why people have a high morbidity mortality later in life, and we think about longevity, which will be, as I'm entering some more information to talk with you guys about, people should have at least 1 day of balance exercises. That could be yoga or other balancing exercises. And the reason why is because your body has an ability to really train what's called proprioception. So there's these little sensors on all your joints, and they tell you where your body is in space. And so in addition to the strength training and the cardio, at least 1 day of balance training is recommended. So a lot of times patients will ask me, why is exercise so important? Well, there's a tremendous amount of evidence now that exercise has the ability to lower your blood pressure by 12 points, lower your cholesterol. It has an ability to have a more functioning pumping heart. It has a huge ability to actually increase bone, also increase muscle mass. It helps regulate your hormones. It's been really important for preventing the decline of cognitive diseases, and also has an effect on improving the bacterial biome in your gut. So we're going to transition from the exercise guidelines that the American College Sports Medicine to what are the things that can help you live longer. And there was a great article I want everyone to be aware about that came out recently in the Front Aging in 2024. And it talked about what is the evidence-based treatment for longevity. As you guys might know, there's a lot of talk and documentaries on longevity, and a lot of people are very interested in this topic. But I'm going to present some of the most evidence-based treatments that we know, and then we'll get into bone health. So this is the pyramid of, I call it the longevity pyramid, and they discuss this in the article. And the way I frame it is there's the bread and butter evidence-based practice basics that we know, and then there's more experimental stuff at the top. And what do we know as a foundation? We know eating healthy, a healthy diet, exercise, specifically sleep greater than 8 hours a day, and following those exercise guidelines are really, really important to living a longer lifestyle. As we progress up the ladder, the next things that come into mind, in addition to 8 hours of sleep and having a healthy diet and exercising consistently, is diet. And in addition, there's been a lot of really good research to have on intermittent fasting. And also there's been good research on eating a limited caloric diet. So if you have a smaller caloric diet, it has a profound effect on your cells, and allows you to live a longer lifestyle. In addition to that, there have been several supplements that there have been good studies on that people should be aware about. Those include NAD plus precursors, spermidine, alpha ketoglutarate, resveratrol, which can be from wine, but the newest recommendations by the CDC, drinking wine is not a positive factor on health, but resveratrol is. Probiotics has also been helpful. So there's been very good evidence on some of these dietary supplements. And as we work up the ladder, there are some pharmacological treatments that people should be aware about. Um, the and they were discussed in this article. But the two of the treatments that have been discussed for a very long time, and we'll talk about it in a little bit. One of them, that NAD plus molecule, which is vitamin B3, has been shown to be an important vitamin to make sure you have in your diet. I highly recommend people read this article. It also talks about some of the experimental strategies, which I didn't want to talk about today, but I just want people to be aware of important things that we know that are evidence-based for living a longer life. As we progress from longevity, one of the most important things for preventing and managing orthopedic injuries is having really strong bones. And as you can see in the guide to the left, having very strong bones can make not only patients happier because they can prevent themselves from falling, but it also can help you have good muscle mass later in life. And that's because the bones and the muscles have an important symbiotic relationship. And so what I see a lot in my clinic are stress fractures. So if you don't have a good caloric diet and it meets the amount of energy that you're expending to the exercise that you're doing, then you have a high chance of getting stress fractures. And there are low risk stress fractures and high risk stress fractures. But the best way that we diagnose these is not by X-ray, by MRI. And so for patients that are runners that have a lot of pain that progressively gets worse in the run, just understand that there's different areas of the body that there are stress fractures. And in order to prevent that, there's some things that I usually recommend patients for bone health. So what are some risk factors that you can change for your bone health? One, smoking and alcohol are not helpful for bone health. Inadequate calcium and vitamin D intake is not adequate for health. Too little exercise or under eating, you can imagine, is not good for bone health. In fact, if your BMI is less than 18.5, you're at risk for osteopenia, which is weakened bones, or osteoporosis, which is a definition of you need to see a doctor for some treatments for your bone treatment. What's important about bone development, and everyone should be aware of, is that your bones have an amazing ability to grow, and they grow and they can build mass from between 20 and 30. And then after 30 years old, you start getting a slow bone loss by a rapid bone loss by a less rapid bone loss. So I really think that the ideal age is between 30 and 60, where you really are wanting to optimize your bone health. And that is usually when people are the busiest in their life, they have a family, but it's really important to think about your bone mass during that period of your life. And what do we know? What does the evidence say today? So if you're a child, 1 to 10 or 11 to 24, we recommend at least 800 milligrams of calcium and 1,200 milligrams of calcium a day. If you're an adult, at least 1,000 milligrams of calcium. If you're pregnant or a lactating woman, you need at least 1,200 milligrams of calcium. One of the people that I see a lot of patients for frozen shoulder, stress fractures, and calcific tendonitis, and that tends to be postmenopausal women. And there's something about their hormones that affect their bone health, but also affect them to get musculoskeletal conditions like frozen shoulder and calcific tendonitis. And one of the most important things I usually recommend for postmenopausal women that are not on hormone replacement therapy is at least 1,500 milligrams of calcium. And then men over the age of 65, 1,500 milligrams of calcium. What's also important to take in consideration is excess salt displaces calcium, and that high phosphate leads the calcium out of the bone. So soda is the worst culprit from this. So if you drink a lot of soda, even diet sodas, you have the ability to take calcium out of your bone. So outside of calcium, there's other things that everyone should be aware of. One, vitamin D is crucial, and not a lot of people get as much sunlight in the Bethesda area. So at least 800 units daily of vitamin D. And if you have a stress fracture, we usually recommend at least 1,500 units to 2,000 units a day. Or if you're osteopenic or osteoporotic, we recommend at least 2,000 units of vitamin D a day. Getting in the sun, your body actually metabolizes vitamin D on its own by sunlight exposure. So making sure that you check your vitamin D and get or either in the sun or consuming vitamin D is critical to optimal bone health. Next is magnesium. 400 to 600 milligrams a day is helpful for magnesium. It's depleted by stress. So if you live a stressful lifestyle, you can be low in magnesium. And then protein. A lot of people think like eating a lot of protein is a good thing, but the real key is moderation is the key. And so women should have at least 95 grams a day of protein. And a high amount of protein, greater than 200 milligrams, is associated with decreased bone density. And low protein diets has been associated with decreased bone density. So why do these bones weaken? It's your hormones, it's your calcium, your vitamin D. But one of the big things is the bones act as a response to stress. So when you strengthen your muscles, your bones get stress put on them, and that stress that's put on the bones makes them harder and makes them stronger. And so that's why strength training is really critical. But it's a big problem in the US. A lot of runners, they like to run. A lot of females, they love doing yoga, Pilates, body weight exercises, but strength training is critical. In fact, osteoporosis is an epidemic that's increasing in the United States. About 10 million people have it, 8 million are women. And osteopenia is the precursor to osteoporosis. So what people should know about is this landmark study that was done in 1994 that they had sedentary people, specifically postmenopausal women, do strength training 2 times a week on 5 machines for a year. And they saw that by doing that, that actually increased your bone density, your spine, hip, and your total body. So it was a really important study showing the importance of strength training to increasing your bone health. And there's been many other studies validating that since. So I strongly recommend people consider strength training from not only living longer perspective, but also from having a good bone health. So I'm going to move on from some of the prevention treatments into some of the non-surgical treatments that I do. And when patients come and see me, we really try to take a holistic approach to what's going on with their injuries. Usually it's not just the one body part. It's usually the part above or below that bothers patients. And when patients come in, I'll use X-ray, I'll use MRI. I'll make sure that in addition to PT, nutrition, and prevention, that I'll use diagnostic ultrasound to diagnose and confirm my physical exam findings, and it's equivalent to an MRI, especially patients that are claustrophobic. We can look at the rotator cuff very well. And then sometimes I can do very precise and accurate injections. I also find it very important for some of these innovative non-surgical treatments that we'll talk about. So the first step of non-surgical treatments that we'll talk about are 5 some non-surgical minimally invasive surgeries that we will do for patients. So these are situations where we might make a small incision, but it's done in the office with local anesthesia, and patients get back to activity pretty quickly. The first one is called 10X. It was a device that was invented at Mayo Clinic. We use it for tennis elbow, golfer's elbow, patella tendonitis, Achilles tendonitis, plantar fasciitis, and calcific rotator cuff tendonitis. And the idea is that these tendon treatments, it used to be called an itis, but now we call it tendinosis. And it's a chronic degenerative disease of the tendons from overuse. So you can be typing and consistently getting some tennis elbow or playing a lot of tennis, but it's an injury to the tendon at where the tendon attaches to the bone that causes a change in the collagen, which is an important makeup of the tendon strength. And when we remove the injured tendon and allow new tendon to grow, which is what we do with this 10X device, we're able to actually see new tendon grow after a treatment like this. And there's been many articles on the 10X treatments, and I'll do it for specific cases. I'll also do it for removing calcium deposits, like when patients develop calcium in their shoulder. It's been very effective, especially for calcific rotator cuff tendonitis. I have many videos of patients that were able to remove these large calcium deposits that build up in their rotator cuff tendons. So this is just what the procedure is. So what it is, I and then we'll use a special device in the office, and we will take that device and go to the tendon that's injured and actually remove the injured tendon or remove the calcium deposit while preserving the rest of the normal tendon. A lot of times patients come to me and they ask, well, doctor, what is the evidence for this treatment? Well, there is a very famous shoulder and elbow surgeon at Mayo Clinic who tracked his patients for 3 and 7 years and showed very good follow-up for a lot of these chronic tendon treatments by using 10X. And as you can see, he followed these patients with ultrasound. So on the upper left screen, you'll see that the patient has a black area, which is a partial tear. The blue and red dots are inflammation. And you can see over time, the tendon fills in where the injured area was treated. And you can see that the patient's pain and function improve. So their pain goes down progressively and their function improves. It takes time. You can see that their pain on average was 5 out of 10, and then it can go down to 2 out of 10. So it takes time for it to work, but it's definitely a treatment for patients that have not improved with physical therapy. They've tried bracing, they've tried non-surgical treatments, and they're looking for other non-surgical treatments before surgery. So sometimes patients will ask, well, how does this compare to surgery? Does this limit me from getting surgery? This does not limit you. This is just a precursor that if you can that is very successful, that is something that can be done instead of surgery. And you can see that when someone did a study of 10X versus surgery for tennis elbow, there was similar treatment outcomes, and this was done at Tulane University. The next thing I'll use 10X for, which I have a great partnership with some of the sports surgeons in my practice with, are for calcific tendonitis. We were talking about that earlier. So you can see in the bottom left screen, there's a large calcium deposit. That calcium deposit is in the rotator cuff tendon. And you can imagine every single time the person raises their arm, that calcium deposit is rubbing along these two bones. And so instead of open surgery, which can take months to heal, in the office, we can use a special needle and we can go into that calcium deposit and remove that calcium with minimally invasive techniques. This is an example of what we do. So we take a needle, that needle goes into this calcium. This calcium is this right here, this bright white spot, and we pull the calcium out because it has an irrigation tool to remove that calcium. And so patients can get back to activity within a week or two. I just saw someone for this recently in the clinic, and they were back to activity within a couple weeks. It ranges from person to person, but it's a very successful, minimally invasive treatment. The next treatment I talk about has been a game changer. There's been over 20,000 procedures performed. It's a device that we use ultrasound to see where the nerve and the artery are. And then we use this device that has a balloon. We use this in the office, so you only need 3 cc's of lidocaine. You don't need general anesthesia. And we can do the whole carpal tunnel surgery under ultrasound. So instead of having an incision in your hand, you have a small incision in your wrist. And then it's a device that goes in there with a balloon to kind of protect yourselves. And then you can do the whole procedure done under ultrasound. This is a video of how it works. So what it is we'll see the artery, the nerve. So patients who have carpal tunnel syndrome, it's the nerve is causing a pinching, and it's causing weakness in their hand and pain in their hand, usually numbness and tingling in the first 3 fingers. And it's what we do, it's due to this ligament. So we use a balloon to open the area up, protecting ourselves, and then a blade comes in and cuts the ligament under ultrasound guidance. It's very quick, it's very effective, and it's done with local anesthesia and can be done in the office. The company is called Sonex, and there's been a lot of studies to date on the procedure. If you go to Mayo Clinic, it's the common procedure that's done for carpal tunnel surgery. In fact, some people will ask, how does this compare to open surgery? And there's been many studies showing very good outcomes in carpal and minimally invasive ultrasound guided carpal tunnel release, and long-term outcomes showing pain function improvement. This was a study in the Journal of Hand Surgery that showed the long-term clinical results of this ultrasound guided carpal tunnel surgery. The next things I'll see patients are for trigger fingers. So what is trigger finger? There are 6 pulleys in your hand, and one of the pulleys in your fingers is called the A1 pulley. And as you can see in this picture right here, people who do a lot of work around the house, use their hands a lot, might have a genetic predisposition, can have pain in their finger, and they can have locking of their fingers. And one of the things that happens is they actually have to unlock their finger. It can be really painful right here on their hand. And we call that a trigger finger. So sometimes we'll do an injection under ultrasound, but when that trigger finger continues to bother them, then we'll do a minimally invasive surgery in the office called a trigger finger release. And so instead of getting general anesthesia, we're able to do these in the office. It's completely covered by insurance, and it's a pretty quick and easy procedure. So you can see here, this is the pulley right here, and then these are the tendons. And we can use a special needle to actually open up that pulley under ultrasound. And people can get back to activity within 2 days after a procedure like this. And all we're doing is using a special needle with a blade to open up that pulley. The next treatment that I'll see patients for, and we talked about the calcific tendonitis for postmenopausal or perimenopausal women. I would say the next most common treatment that I'll see for perimenopausal women is frozen shoulder. So what is that? That is where they have restriction in range of motion in both active and passive range of motion, and it happens for no reason. Sometimes it could be they're pre-diabetic, sometimes there's a thyroid cause, or sometimes they're just perimenopausal or postmenopausal, and they have this situation where there's inflammation of their shoulder capsule that causes frozen shoulder. So this is the treatment that we do for it. Let's talk about one treatment option for frozen shoulder. This injection is a solution of saline, lidocaine, and steroid, which goes directly into the shoulder joint under ultrasound guidance, breaking up adhesions and expanding the joint capsule. This patient has been doing physical therapy, but was seeing limited improvement. Immediately following the injection, you can see the difference in her range of motion. The patient received immediate relief after the procedure.
Wow. Pretty amazing.
This technique is used in conjunction with physical therapy as part of our integrated medical practice. So that procedure is extremely effective. It's about 90% effective. Patients come in, they can't move their shoulder, their shoulder is frozen. And with one capsular distension injections covered by insurance and I do a small mobilization technique, and then I send them straight to PT afterwards. And so the key is doing the PT right afterwards and doing this ultrasound guided capsular distension. We're able to completely cure patients for frozen shoulder, and it's been very effective. So we're going to move on from some of these non-surgical, minimally invasive treatments, and we're going to talk about the management of hip and knee arthritis. One in two Americans will suffer some arthritis in their ages. You know, the way I always explain in my practice is if you're over the age of 40, you're starting to get a little bit of arthritis. And that's not a bad thing. It's a progressive disease, but because we're getting a little bit older, you get a little bit of arthritis that happens. And as you can see on the left screen, this is a very severe arthritis, but and then this is a normal hip. And then you see on the right screen, this is a normal knee, and then a more osteoarthritic knee where the bones are touching. But you know, arthritis is a spectrum. So the way arthritis happens is that there's some type of inflammatory cascade. It causes a little bit of the cartilage to happen, even causes inflammation, swelling to happen in the knee. And then eventually over time, the bones will start getting closer together, which you have probably heard as bone on bone. But between bone on bone and the early precursors of arthritis, there's a lot of treatment options that can be used to help patients manage arthritis. And I will be focusing on all those options and talking to you about some of those treatment options. So there's steroid, which has been around, or cortisone, people have heard that. There's removing the fluid when you get fluid in your knee. There's hyaluronic acid, that's a gel, that's a lubricant for the knee, that's covered by insurance. And then there's more evidence on these regenerative medicine treatment options, which we'll talk about. So the things that I do in my practice, which are FDA cleared and are allowed to be done by the FDA, which is really important. There's PRP, that's where we take your blood and we get the platelets, and those platelets are injected back into the joint or tendon. And then there's stem cells. We'll talk about a little bit of both of those. The first one is PRP. So PRP is where we take your blood and we get the blood, and we get about 60 cc's, and we centrifuge that blood into three components: the plasma, the buffy coat, which is where the platelets are, and then the red blood cells. And the buffy coat, where the platelets are, is where there's a lot of growth factors that help with a whole host of treatment options for arthritis, which I'll go over, and a whole host of treatments for tendon injuries. What's important that I am doing, what I learned at Mayo and what I brought back to the practice, in addition to PRP, which is really being done at every academic institution, a lot of practices do PRP. One of the things that we're also doing now is A2M, which is alpha-2 macroglobulin, which is the anti-inflammatory molecule that we get from the plasma. The good news is that these things are very safe, and if done in the right person for the right condition, can be very effective. So PRP, people are using for everything. People are using it for hair loss. There's been a lot of good studies for hair loss. People are using it for their face and skin to rejuvenate their skin. In orthopedics, we're using it for arthritis, for tendonitis. That's been most of the research, and then sometimes for muscle and ligament injuries. So the patients always ask me, what is the science behind treating arthritis using some of these treatments? Well, the way I explain to patients, arthritis is caused by markers of inflammation, which cause eventually cartilage to break down. And PRP adds growth factors, which are your own body's ways to heal, to stimulate either managing of the arthritis, or it helps to actually treat the tendon that's injured. It's very safe, and depending on the condition, can be very effective. These are all the growth factors that are involved. I won't go through them here, but I'll explain it in this picture here. So essentially, PRP does three things that I always explain. It does not regrow cartilage. People should know that. It's very important. That does not regrow cartilage. It decreases their pain a lot longer than a, a normal injection. A steroid injection can work within 7 to 10 days. A PRP injection, you have increased pain for 3 days because it's pro-inflammatory, and then it takes 3 to 6 weeks to work, and then it can take and then it can last for years. On average, at least 1 year, but I've seen in patients about 3 to 5 years for arthritis, and then for tendons, it can be a long-term treatment option. The second thing it does, it brings blood supply to the area. Anyway, anytime you can bring blood supply to a tendon or the joint, it can be helpful. And then for a joint, it's cartilage protective. It kind of puts a shield around it. So the way I explain it to patients, it decreases inflammation, it brings blood supply to the area, and then it's cartilage protective. What's important to know is your age, your BMI, so how much you weigh, matter. And the older you get, the platelets aren't as good. But depending on how healthy you are and your platelets and your BMI, that all makes a factor into getting amount of platelets. And there's been a lot of research showing that at least 10 billion platelets is the adequate dose for a right treatment, which is what we do here at Orthopedic. So a lot of times people will talk about the studies. So there are studies that are mixed for PRP, and people are doing it for every condition. But if you stay in your lane of doing it for the right condition, it can be very effective. In fact, for mild to moderate arthritis, which most of the studies have, a lot of studies have been on, I've seen it, there's many single-blind, double-blind, randomized control studies showing it to be very effective. This was a study done from University of Colorado. This is a study on the right showing it delays the need for a knee replacement. This was a study done in Baltimore in the Journal of Medicine at Hopkins, showing a systematic review and meta-analysis of randomized double-blind control trials. So that means the doctor didn't know, the patient didn't know, showing that PRP can significantly improve their pain, their function, their quality of life. So the evidence for knee arthritis, for mild to moderate knee arthritis, has been very clear, and there's a lot of studies supporting it. For tendonitis, there's been, this was a study done at Stanford that was done in 2014. It was a double-blind randomized control study showing that PRP was effective for tennis elbow. And some patients ask me, what does it seem like? Well, like what do patients feel? Well, here's an example of a patient I did for tennis elbow.
So this patient's 2 months after PRP for her elbow. She's been having pain for over 2 years now. Do you mind telling the doctor about how you're doing?
Sure. So I had the PRP procedure done 8 weeks ago, and at about the 6-week mark, I really started feeling improvements. The pain decreased from the touch and movement, and now at about 8 weeks, my pain level is about a 2. Periodically after physical therapy, this is the best I've felt in 2 years since we've been trying to address this elbow tear and rotator cuff. So this elbow tear, this is the best I've felt in 2 years. So I'm amazed after 8 weeks how much my pain level went from an 8 or 9 to a 2, and it's intermittent. It's not consistent anymore. So this was the right thing for me. I'm so glad I was referred.
So she is a very classical patient. We'll see. You'll see that her pain goes down a lot. She still has a little bit of pain at the 8-week mark. It takes time for it to work, but it's been a lot better. She's someone who's tried physical therapy, steroid injections. She tried the gamut of non-surgical options. So there has been this for trochanteric bursitis and glute tendinopathy. People have also seen it for golfer's elbow. This is a study done at Tulane for golfer's elbow. There's been studies for Achilles tendinopathy. I have to be honest with Achilles tendinopathy is very complex, and it depending on how severe your Achilles tendon is. But there's been mixed studies for the Achilles because of that. But overall, it can be effective for Achilles tendinitis. So the way I explain to a patient for arthritis, it will be effective. It should last at least a year. For tendinitis, it's a long-term treatment. On average, for arthritis, it can last up to 3 to 5 years. So the next thing I'll talk about stem cells. I'll talk about it very briefly, but stem cells are, we get it from your bone or we get them from your fat. Stem cells, there are these signaling cells. They're like PRP, just a little bit more, I would say, and they have the ability to differentiate into other tissues. It's very early, it's very experimental. We don't have good research. There are some FDA trials coming out. At Mayo, we were working on an FDA cultured stem cell study. There was a DNA virus. There's actually one product that's using adipose, which is what we used at Ortho Bethesda, called a product called Lipogems that could get FDA approved this year. But it's a double-blind randomized control. These are some studies showing effectiveness, and there was a study done at Rothman in Philadelphia with Thomas Jefferson University showing a double-blind randomized control study showing the adipose treatment to be very effective. And it probably works longer and works better for later stages arthritis, but still not severe arthritis. If you're severe arthritis, that's when knee and hip replacements are the appropriate treatments. This was a study done at UCLA, USC, that showed that it was very safe. So we know now that PRP and stem cells are very safe. There's been a lot of evidence showing that. So about 80% effectiveness, 85% effectiveness, and getting the right condition. And we're trying to figure this out every day. It's the holy grail in medicine, but we do know it's very safe. This was a study done at Emory University showing 2-year outcomes for adipose stem cells. And what I want people to know is because there's been a lot of studies in this area, the NBA came out with a consensus statement supporting PRP for knee arthritis and patellar tendonitis. And they put together a very good statement that was performed at Rush University with the team physician of the Bulls there. And then the American Academy of Orthopedic Surgeons wrote a really good technology assessment of PRP and went through all the studies. So I highly recommend that if patients want to learn and read about it, they can find it on my website, drmarcgruner.com, or they can go on the American Academy of Orthopedic Surgery website. What's really important is finding the right conditions and also understanding that it takes time and putting them on the proper rehab protocol. And so what I've worked on and talk about nationally is rehab programs for after a regenerative medicine treatment. And we break it down. This is the chapter I wrote with some physicians from Emory University, that there is some inflammatory cascade that happens, and then there's tissue that's built, and then there's more tissue that's formed. This is for a tendon that happens. And you can see that it takes weeks, and we try to mirror the rehab program to how to the healing that's happening at a biomechanical level. We talked about this briefly, but there's a lot of uses of ultrasound that I use in my clinic. So it's not just the treatment, but it's getting the right diagnosis. And so I use ultrasound to see if there's a torn rotator cuff, if there's a torn tendon in their elbow. We can measure the nerve for carpal tunnel and tell patients right away if they have carpal tunnel. We can look at swelling in their knee, and we can see a lot of soft tissue injuries. What people should know is that the ultrasound is equally effective to MRI for a lot of these soft tissue injuries if it's done in the right hand. And it's quick, it's cheap, effective, covered by insurance, and it's done in the office. So you can really take the history, the exam, the x-ray findings to put together the best package for what's going on for the patient. What's really important to know is that there was a study done at Hershey Medical Center, and that ultrasound is not only good for diagnosing, but making sure it's accurate, precise injections. So we use ultrasound for all of our injections, and we'll make sure that it's put in the right spot. And there's studies showing support of that. In fact, one study that was done at Mayo Clinic where I trained, and half the patients for knee arthritis got ultrasound guided hyaluronic acid injections, and the other got landmark guided. It means they were not using ultrasound, and they followed these patients out for 10 years, and you saw that the patients had the ultrasound guided treatments has a significant delay in their knee replacement. So it's really important to think about the ultrasound use. And if you put the whole package together, we have a registry here at Ortho Bethesda, and we try to be transparent on our outcomes. And we've seen that patients who are getting the right condition, we have very defined conditions for it, their pain and function can significantly improve and last for several years. So that's just a little bit about myself and some of the non-surgical treatments, some evidence about prevention, diagnosis, and treatment. I want to answer any questions that you guys have, and hopefully, if we can't answer the questions in the next 10 minutes, we'll talk about. I'll make sure that Myrna gets me a list of all the questions.
Yes, so I did keep a track of all of the questions everybody has been sent either to me or to through the Q&A portion, and I can just give Dr. Gruner a little bit of some of the questions. So there has been a ton about the PRP. Can they be used on people with alopecia, hair thinning?
So it can be. I don't do that. I've done it for my wife for TMJ syndrome, but uh, I I don't do that. But it can be done for alopecia, and it's done at a lot of practices in the DC area. The other thing that you guys should, someone asked about turmeric. I want to make sure I say that there have been some studies supporting the use of turmeric. If you look at the study, it's 500 to 2,000 milligrams a day. I strongly recommend patients try that. It's a potent anti-inflammatory. You actually have to, there's certain ones that you have to get for it to be effective, but it's something that's naturally that you can take, and there's been some studies supporting it. I recommend patients take it for a month, and see and make sure that they check in with their medical team first. But if they don't see an effect, which it's not all the time you see an effect, then I wouldn't continue taking it. But turmeric has been shown to be helpful in some studies.
Perfect. Thank you. We also have questions about the Texit, the procedure that you use for
10x.
10x. Thank you. Has it been tried to be used for torn or frayed meniscus or for arthritis?
It has not been used for arthritis or torn meniscus. It's for tendon injuries and calcium deposits that form.
Okay. So if there is so a shattered vertebrae, if it's held up by small pieces of vertebrae, no osteoporosis, now a small crack in a tiny piece of the vertebrae, is there anything that can be done, or that's for a spine specialist?
Yeah, so I deal with shoulder, elbow, wrist, hand conditions. I do hip, ankle, feet. I would visit a spine specialist to talk about that question.
Yes, so anything spine related, we do have an upcoming lecture on spine. Dr. Fauschbaum will be discussing everything spine. So if you are curious or have any questions regarding spine, please join that lecture and he'd be happy to answer any of your questions for spine. Any other quick questions? Oh, a lot of people want to know if PRP is covered by insurance.
Yeah, so I want to make sure. Yeah, I should have said this. So most of the procedures that I discussed were covered by insurance. PRP and stem cells are not covered by insurance. There's a whole host of reasons why that's not the case. It's covered for very, very select insurances, but for the vast majority of patients, it's not covered. That's correct.
How many injections do you typically need for PRP for knee arthritis?
Yeah, for knee arthritis, one PRP injection, and people should know it's $1,000 at our clinic. Should last you at least a year if it's in the right condition that's being treated for it. And and once again, I see 3 to 5 years of of how long but it should last at least a year.
Okay. Is there a test to determine if you have any existing, like what kind of bone density you have? Is there a specific test for that?
Yes, this is very important. So, and I want the whole, if you can hear me, just like growing up in the area, going to high school in Bethesda, I want people to really have good knowledge of the right diagnosis and treatment. That there's a test to get your mineral density. We don't offer it at Orthopedic, but you go to your rheumatologist or an endocrinologist or the radiologist. There's radiologists that can do this, but it's called a DEXA. And what's really important, if you're over the age of 65, you can get their T scores, which looks at your bone age compared to other 65-year-old people. But if you're a young athlete or you're someone in their 40s and getting a DEXA because they're concerned about, you have to look at Z-scores, which means I want to see what my bone density is to other people that are the same age as me. So that's an important test to look at how your bones are.
Perfect. What do you recommend for ongoing treatments for patients who have like Ehlers-Danlos syndromes or anything like that?
That's a complicated condition. It all depends what it is. They have looser tendons, so that's a probably more complicated question. One of the questions here is ultrasound versus X-ray guidance. I want to be very clear with everyone. Ultrasound guidance is way more accurate and more effective than radiological guidance, unless you're doing it for the spine. And it's less radiation on the patient.
For those wondering, we will be sending out this recording. I will keep track of all the questions, hopefully to get everything answered to be sent out to you. There is there's 6 other lectures within different body parts that is posted on our website for you to sign up and attend. If there's any more questions, thank you, Dr. Gruner.
Yeah, I want to thank you guys. I'm really excited that Myrna is helping us put this on, and I think our goal at Ortho Bethesda is we want to get you guys evidence-based treatment from a lot of the doctors in our group, and I'm happy to be the first one and the guinea pig for our group, but to put it on this year. But I'm really excited to this. I think we're going to have great lectures, and the video will be available for patients. And for any patients that have any questions, they can make appointments both in Bethesda, but also in Tyson's, our new facility.
Yes, you will be getting a follow-up email with the recording. We will try to get every question answered, and it would also contain the link to schedule an appointment with Dr. Gruner or any of our wonderful doctors in all of our 4 locations, who we cover a ton of specialties. If you have any questions, please send them directly to me. I will list my email, or to Dr. Gruner. I can also list your email if you'd like.
And I just had one other question. People are asking if I practice in Bethesda and Tysons. So I practice in Bethesda and Tysons, both, and taking new patients all the time. So thank you so much.
Of course. We also have location in Rockville and Germantown, with the multiple locations for PT on site. Tyson location actually has X-ray and ultrasound. So if the docs would like to get you scheduled for that, that's something we can do on site.
Thank you guys very much.
Have a great day.
And then wait, Myrna, where can people get the webinar link? I know there was a lot of people that
The recording?
the recording.
Yes, it will be sent out to them.
Okay, perfect.
Once we end this, yes, of course. Have a great day, everybody.